Welcome back to the deep dive. We are doing something a little specific today. We are heading straight into the trenches of the hospital floor. I want to talk to the nursing students listening right now, or, really anyone who spends their day in scrubs.
It is a specific audience, but I think the topic is pretty universal. We're looking at the mechanics of human connection, but in these really high-stress environments.
Right, but let's set the scene for the students first. It's shift change. The unit is just chaotic.
Yeah.
You've got 3 call lights blinking like a disco in a nightmare. You have meds to pass, charts to fill, discharge papers to print. And in that environment, you have this immense, crushing pressure to treat the patient like a checklist.
Exactly.
Temperature? Check. Blood pressure? Check. Pain scale? Check. And you move on.
That is the reality. It's kind of an assembly line model of healthcare. It's efficient, it's organized, and according to the research we're covering today, this is Chapter 4 of Health Communication for Professionals, it's also where the diagnostic process often completely falls apart.
That is a terrifying thing to say to a student who's just trying to survive a 12-hour clinical rotation without, killing anyone.
Right.
The idea that the checklist, the very thing keeping them organized, is actually the enemy.
Well, not the enemy, necessarily.
Yeah.
But maybe a blinder. The text calls this the biomedical model.
The biomedical model.
Yeah. It's the standard training. Find the symptom, isolate the biological cause, fix the machine. But the argument here is that communication isn't just a soft skill.
Right. It's not just being nice.
Exactly. It's a high-stakes diagnostic tool.
Yeah.
And if you break that tool, if you interrupt or assume or stereotype, you might get the right data points, but you'll often get the completely wrong clinical outcome.
So our mission for this deep dive is to sort of dismantle that biomedical interrogation style and replace it with what the text calls a patient-centric approach. And I want to be clear, we aren't just talking about holding hands and singing songs here. We're talking about specific, actionable techniques to decode what a patient is actually telling you.
Which, as we're about to find out, is rarely what you think they're telling you.
Let's start with that disconnect. The source material introduces this concept of the narrative versus the checklist. It makes a cultural point that I think we just take for granted. Human beings, especially in American culture, process their reality through storytelling.
Would you? I mean, think about how you make sense of your day. You don't recount it as a series of timestamps and biological functions.
Yeah.
You tell a story.
Yeah, I was walking to the car, and then this happened, and I felt this way.
Exactly. When we get sick, we don't naturally switch into medical report mode. We tell stories about our sickness to connect with people, to make sense of it.
The text gives this really great case study to illustrate this. 2 friends, Jill and Jean. Jean's the sick one. And I want to really dissect this conversation because it shows what a natural human interaction looks like. Jill starts by saying, "I missed you in calculus."
Right. And just notice that opening. Jill asks, "What's up?" It's an open door. She invites the narrative.
And Jean doesn't say, "My temperature is 101.4 and I have localized pharyngeal pain."
No.
She says, "I woke up last night soaked in sweat. I felt like I was burning up. My throat hurt so bad I couldn't even drink water."
That is a narrative.
Yeah.
It's emotional. I felt like I was burning up. It's contextual. She's painting a scene. And Jill, as a friend, she responds with empathy.
Yeah.
She asks if Jean went to the health center. It's a dyadic exchange, a two-way street where the sick person feels heard and supported.
Exactly. Jean feels better just by telling the story. But now let's look at the clinical disconnect. The text contrasts this friend conversation with what happens when Jean actually goes to see a provider. And this was painful to read because I think everyone listening has either done this or had it done to them.
It's the classic clash of cultures, isn't it?
Yeah.
The patient comes in with a narrative, and the provider comes in with an algorithm.
So in the example, the provider walks in and says, "What can I do for you?" Jean starts, "I'm not feeling good." And immediately the provider cuts in, "Do you have a fever?"
That's the first interruption.
Yeah.
The provider has already entered biomedical mode. They aren't listening to the story. They are filtering for symptoms.
Jean says, "Yes, and." The provider cuts in again. "How high?"
Yep.
Jean tries to explain, "I don't have a thermometer, but I woke up sweaty." And the provider interrupts again. "Well, your temp is normal here. Are you coughing?"
You see what's happening.
Yeah.
The provider is hunting for data. They hear sore throat and congestion. They rule out the fever, and they jump straight to viral versus bacterial.
Right.
They're solving a puzzle, not talking to a person.
And, okay, playing devil's advocate here, strictly clinically speaking, the provider is probably right. They diagnose her with a virus, rule out strep, prescribe fluids, job done. Why does the communication style matter if the diagnosis is correct?
because compliance relies on trust. The text points out that Jean walks away from that encounter feeling minimized. She thinks, he didn't even let me finish my sentence. How does he know I don't have something serious? Maybe I should have mentioned the dizziness, but he never gave me a chance.
So she leaves with a prescription she might not fill because she doesn't trust the person who wrote it.
Precisely. You sacrifice the outcome for speed. The text actually references research on this, on interrupting. It suggests a little social experiment. Try interrupting a friend every time they speak for 5 minutes.
I feel like that is a good way to lose a friend.
It creates immediate hostility. But we do it in medicine all the time because we hide behind the checklist. We think efficiency justifies the rudeness. But the source argues that interruption signals a power imbalance.
My time is more important than your experience.
That's it. And in medicine, that imbalance destroys the therapeutic relationship.
So for the nursing students listening, the lesson here isn't to ignore the clinical data. It's that you can't get the full picture if you treat the patient like a broken car engine instead of storyteller.
That is the core conflict, absolutely.
So how do we fix this? We need tools. The source material outlines a toolbox for better communication, starting with active listening. And I feel like active listening is a buzzword we hear a lot in HR seminars.
It is.
But what does the text actually say it looks like in a hospital room?
Well, it's physical and it's verbal. Physically, it implies, I am here. It's leaning in. It's nodding. It's maintaining eye contact.
It's not looking at the door.
Exactly. It's signaling, I am not looking at the door, I am looking at you. And then verbally, it's feedback. It's restating what you heard. So you're saying the pain gets worse when you lay down.
But the most tactical tool in the box, the one that actually helps with the checklist, is understanding the difference between open and closed questions.
This is crucial. Closed questions are the checklist questions. How high was your fever? Does it hurt when you breathe? Are you coughing up phlegm? They are designed to limit feedback.
They demand a short, specific answer.
Yes, which is useful sometimes, right?
Of course.
Absolutely. You need closed questions to refine the data after you have the story.
Yeah.
The problem is starting with them. If you start with a closed question, you train the patient to only give short answers for the entire encounter.
So we should start with open-ended questions.
Yes. Tell me why you came in today. How are you feeling? These invite the narrative.
But I can hear the nursing students screaming at their phones right now. I don't have time. If I ask an open question, Grandma is going to tell me a 20-minute story about her cat and her grandkids, and I have 6 other patients.
That is the common fear. The Pandora's box fear. If I open the lid, I'll never get out of the room. But the source material addresses this head-on. It suggests a strategy called the 2-minute rule.
2 minutes.
2 minutes. Research suggests that if you ask an open question and just let the patient talk without interrupting, they will usually exhaust their main narrative in under 2 minutes.
No way.
Usually closer to 90 seconds.
That seems incredibly short.
It feels long when you're standing there, but it's actually very efficient. And guess what? Most of your diagnostic checklist questions get answered naturally in that narrative. They'll tell you about the fever, the duration, the severity, the triggers.
So instead of asking 10 questions and getting 10 interruptions and 10 short answers, you listen for 2 minutes and get the answers to 8 of them, plus the context.
Exactly. It's actually more efficient. And more importantly, it's an act of empowerment. The text defines empowerment as providing patients with info to participate in their care.
Yeah.
But it starts with sharing the power of the conversation. When you listen, you treat the patient as a partner, not a subject.
I love that. It turns the patient into a team member. Now, speaking of the patient, one of the biggest sections in this source is about audience analysis, because a patient isn't just a generic human body.
Right.
Communicating with a 5-year-old is different than communicating with an 85-year-old.
This is so critical. In public speaking, we analyze the audience to tailor the message. In nursing, you have to do this for every single room you walk into. You have to pivot your style instantly. Let's look at the life cycle, starting with pediatrics.
The kids, the text mentions a trap here that I thought was fascinating. The veterinary trap.
It is a harsh term, but if you've spent time in pediatrics, it's pretty accurate. Think about when you take a dog to the vet. The vet talks to you, the owner.
Right.
They examine the dog, but they don't really consult the dog. In pediatrics, providers often do the same thing. They talk exclusively to the parent and treat the child like, well, like a pet that is just there to be examined.
And the kid is just sitting there terrified, being ignored.
Right. It increases anxiety, which makes the heart rate go up, which makes the exam harder. The better approach is to acknowledge the child first. Before you even talk to the mom or dad, look at the kid. Get on their physical level.
The text suggests asking about non-threats. School, toys, cartoons.
Yeah, there's a research exercise suggested in the text that I think is great for students. Find a 5 to 10-year-old, with permission, of course, and just try to start a conversation about their toys. See how quickly you can build rapport.
It's amazing how disarming it is when an adult actually takes an interest in a kid's world. It changes the dynamic from scary doctor visit to meeting a new person.
And you have to explain before you touch. I'm going to listen to your heart now. The stethoscope might feel cold. It gives the child a sense of agency over their own body.
Now, let's jump to the other end of the spectrum. Geriatrics, the aging patient.
Interestingly, the trap here is very similar to the veterinary trap. We call it the caregiver trap.
Okay.
Providers often talk to the adult child, the daughter or son in the room, rather than the elderly patient.
Because they assume the patient can't hear or understand.
Often, yes. Or they just assume it's faster to talk to the younger person. But unless the patient is cognitively impaired, this is incredibly disrespectful. You need to focus on the patient.
But there are physical realities to consider, right? The text talks about sensory adjustments.
Yes, you absolutely have to. You have to analyze the audience's physical capabilities. Volume check if they can hear you. But don't just shout. Shouting distorts the sound and can sound angry. Check if they have hearing aids.
And pacing.
Slow down. And visuals. If you hand them discharge instructions with 10-point font, you might as well hand them a blank page. Use large print. But the biggest don't in this section is elder speak.
Oh, this is a big one. Elder speak is that sing-song, high-pitched baby talk people sometimes use with old people. How are we doing today, sweetie?
Did we eat all our oatmeal?
Yes.
It's paternalistic and condescending. It just strips the patient of their dignity. The text makes it so clear. The tone should be conversational and respectful. You are talking to an adult with a lifetime of experience, not a toddler.
The text also mentions that with this demographic, you have to have the crucial conversation.
Right. Advanced directives, living wills. The source emphasizes that you shouldn't wait for a crisis to bring this up. If you're doing a thorough history, these topics need to be on the table. It's about normalizing the conversation about end-of-life wishes, so it isn't a panic decision later.
Okay, so we've done kids, we've done the elderly, and now we have to talk about the in-betweeners, adolescents.
The trickiest demographic, I think,
Why is it so difficult?
because they're in flux. They're hormonal, emotional, physically evolving, and they are desperate for privacy. The biggest conflict here is the privacy conflict. They often have health concerns, especially sexual health, substance use, or mental health, that they do not want to discuss in front of their parents.
But the parents are usually right there in the room, so how does a nurse navigate that?
You have to navigate the chaperone situation. The text suggests addressing the elephant in the room. You can ask the teen and the parent, would you like mom or dad to stay for the physical exam? Or, I'm going to spend a few minutes talking to the patient alone.
That puts the ball in their court.
It does. And treating the teen as an emerging adult builds massive trust. You're signaling that you respect their autonomy.
And specifically regarding sexual health, the source notes that this requires a lot of trust.
It does. Adolescents will clam up if they feel judged. A really great tip the text offers is to use written materials first. Hand the teen a pamphlet or a sheet about STDs or safe sex. Let them read it privately for a moment.
It takes the pressure off the face-to-face interrogation.
Exactly. It allows them to absorb the info without the awkwardness of eye contact during the explanation. Then you can answer questions. It creates a buffer. It's about correcting misinformation, about sex, STDs, pregnancy, without judgment.
Moving on from age, there are other hidden barriers to communication that I think are even easier to miss. We assume that if someone is nodding and saying, they understand us.
Yeah.
But the source material drops some pretty shocking statistics on literacy.
This is a real wake-up call. The text cites that 15% of American adults cannot read effectively. They are functionally illiterate. And a staggering 20% read below a 5th grade level.
That is 1 in 5 people walking into your clinic.
1 in 5. So when you hand someone a preoperative form or a complex medication schedule, there's a very real chance they literally cannot read it.
And they aren't going to tell you, hey, I can't read this.
No, of course not. They will hide it out of shame. They have spent their lives hiding it. They'll say, oh, I forgot my glasses, or I'll read it when I get home, or my hands are shaking, can you fill it out for me?
So how do we assess this without being offensive? We can't just ask, can you read?
No, you can't. You have to assess health literacy, which is different from just reading. It's about understanding context. The source suggests some really clever embedded tests woven into the conversation. For example, the avoid alcohol test.
Okay, walk us through that.
You ask a patient what avoid alcohol means to them regarding their medication, and you might be surprised. Some think it means don't drink whiskey, but beer is fine. Others might think it means don't use rubbing alcohol on my skin.
Wow, I hadn't even thought of that. If you don't clarify, they could be drinking beer with the medication that causes liver failure.
Exactly. Another one is the citrus test. If a label says avoid citrus, ask them to name citrus fruits. Can they actually identify that grapefruit and lemons are in that category, or do they just know the word citrus?
The source also suggests something called the hurricane test for reading level.
This is a way to check reading ability without using scary medical terms.
Yeah.
You have the patient read a simple, fifth-grade level paragraph about hurricanes. It's neutral, it's not threatening. If they struggle with that, you know immediately that handing them a complex packet on diabetes management is going to be completely ineffective.
You have to switch to pictures or verbal instruction.
Or teach-back methods, exactly.
That leads us directly into socioeconomic status, or SES, because often the medical advice we give is clinically perfect but practically impossible.
This is the diet disconnect. A nurse might tell a patient, you need to lower your cholesterol. Eat fresh vegetables, lean proteins, grilled salmon, quinoa.
Which is great advice.
It is if you have the money at a grocery store nearby.
Yeah.
But if that patient has a food budget of, say, $1.50 per meal, they are buying a fast food burger. They aren't buying salmon.
The text calls this similarity bias.
Right. We tend to communicate easiest with people who are like us. Most doctors and nurses are educated and have a certain economic stability. We subconsciously assume our patients have the same resources. We assume they have a fridge. We assume they have a car to get to the pharmacy.
And patients often assume the provider is rich and different, which creates a wall.
So the takeaway is, assess the patient's reality before creating a treatment plan. If you prescribe a lifestyle they can't afford, you haven't actually treated them. You've just given them a task they will fail at, which leads to shame and worse outcomes.
This brings us to the final major section of our deep dive, stereotypes and gender. And the text makes an important distinction here between sex and gender.
Yes. In this context, sex is biological, male, female. Gender is behavioral and social. It's how we communicate.
So you can have a masculine-gendered communicator regardless of whether they are biologically male or female.
Correct. The text describes masculine-gendered communication as generally more competitive, interrupting more, giving less info, being more just the facts. It's instrumental. Feminine-gendered communication tends to be more detailed, asks more questions, and is more relational.
And the risk here is how we interpret these styles clinically.
It's a huge risk. If a patient is a feminine-gendered communicator, maybe a woman or a man with that style, and they give a lot of detail and ask a lot of questions, a busy nurse might dismiss them as chatty, anxious, or hypochondriac.
Oh, she's just worrying too much.
Right. And conversely, a masculine-gendered patient who is quiet, stoic, and doesn't offer info might be in severe pain. But because they aren't complaining, the nurse assumes they're fine.
So we are misdiagnosing based on communication style.
We are. We have to look past the style to get to the substance.
And that leads to the ultimate stereotype challenge in the book, the motorcycle guy.
Ah, the motorcycle guy. This is a classic scenario to test your implicit bias.
Let's set the scene. A 35-year-old male comes into the ER, crashed his motorcycle, broken foot, road rash.
Okay, be honest. What is the first thing that pops into the average person's head?
Leather jacket, maybe some tattoos, risk taker, reckless, maybe a gang member.
Exactly. Donor cycle, right? We have these immediate biases. We see risk taker, we see reckless.
But the text hits us with a reality check.
Who rides motorcycles? Lawyers ride motorcycles. Judges ride motorcycles. Doctors ride motorcycles.
So this guy could be a surgeon.
He could be a federal judge. But if the staff stereotypes him as a ruckless biker thug, what happens?
Wow.
They might assume he's drug-seeking if he asks for pain meds. They might minimize his pain. They might spend less time communicating because they assume he isn't one of us.
And the solution isn't to pretend we don't have these thoughts.
No, that's impossible. The solution is intrapersonal analysis. You have to check yourself. You have to catch that thought, oh, I'm judging this guy, and stop it before it affects your care. You have to say to yourself, I am treating a broken foot, not a stereotype.
It really all comes back to that central theme, doesn't it? Seeing the person, not the category.
It does. Whether it's age, literacy, or a motorcycle helmet, categories blind us. Communication opens our eyes.
So let's summarize what we've unpacked today for our nursing students. Your mission is to move away from the biomedical checklist and embrace the narrative.
It's a cycle. You have to listen actively, use those open-ended questions in the 2-minute rule. You have to analyze who you are talking to. Are they a child? An elder? Can they read? Can they afford the treatment?
Right.
And you have to check your own biases so you don't shut them down before they even start speaking.
Don't just fix the broken part. Connect with the person.
That is the job. That is the art of nursing.
Now, before we go, the source material offers a specific challenge for our listeners. It's called the eye contact challenge.
I love this one. It sounds simple, but it's intense. The challenge is this. Have a conversation with a friend or family member for a few minutes and focus only on their eyes.
Ignore your phone.
Ignore the phone, ignore the TV in the background, ignore the itch on your nose. Just lock in and see how it changes the feeling of connection. It's a powerful way to retrain yourself to be present, which is the foundation of everything we discussed today.
I'm going to try that tonight. Just a warning to my friends, I might look a little intense.
It's good practice.
Here's a final thought to leave you with. The text mentions that knowledge is only valuable when it's understood and applied. So ask yourself this. If a patient leaves your clinic with a prescription they can't read, or a diet plan they can't afford, or a diagnosis they don't trust because you interrupted them, did you actually provide any health care at all?
That is the question.
Something to think about on your next shift. Thanks for diving deep with us. We'll see you next time.